It's been 7 years now, right? It's been a long time, yeah. So, yeah.
Could we spend just a moment to explain how you and I met? Do you remember that? The pace race in Kirkland? You came over to the table, we had the resource table,
Yeah.
and you identified yourself as Dr. Porter. Well, we just had a Dr. Chris Porter talk to our group, and you said to me, "Why am I not invited?" And you went for shortly after that.
So we have a standing joke, Chris and I, because there's a lot of confusion, actually. I mean, I don't know, you have to...
You don't
probably-
look alike.
Well, we don't look alike, but the name gets people confused because the Dr. Porter in Seattle, we both do prostate cancer surgery, and the standing joke is that he sees a lot of patients that come to see me, so his practice, I build his practice for him, so, so just based on name alone.
Whatever works.
But this is great, I'm really honored to be here, thank you for inviting me, and I can just give you a little story about what I have in common with a lot of you guys, and that is, I don't have a prostate either. So there's a lot of people in this room that don't have a prostate. Well, I'm in the same group. I was, you know, at the University of Washington doing my doing robotic surgery at the time, and the story goes, I went to Germany to learn laparoscopic surgery. This is actually 1997. This is pre-robot, and laparoscopic surgery was not very popular in the U.S. yet, but the Europeans had actually kind of moved it forward, and they were taking out the prostate laparoscopically, which was a very difficult operation. It had been tried in the U.S., but the early experience was it was not a very good procedure, complications were high, but a group in France actually figured it out, and I remember seeing them do one of their procedures thinking, wow, this is really in advance. So I went to Germany in '97 to learn laparoscopy, and spent 6 months there, and learned kind of the basics of laparoscopic surgery. And then in 1999, when it became popular to do it on the prostate, I started doing that in Europe as well. I went back to Germany, and we started doing the procedure there. And so then I brought that back to the U.S., to the University of Washington, and we started doing our first prostates laparoscopically. Again, laparoscopically is quite different than robotics because you're working in 2 dimensions. So you're working on a television screen, you don't have depth. And so it's much more difficult. And the instrumentation is, there's straight sticks, there's no articulation, there's no wrist. So it's very difficult to do things like suturing, or gain angles for nerve sparing, or do lymph nodes, because the instrumentation is much more difficult. So laparoscopic surgery was a very difficult type of approach, but I did it for many years. From '97 until the robot came along in 2003, I did everything laparoscopically, and not just prostates, but kidneys and testicular cancer, a lot of other things. But, so I went there, learned laparoscopic surgery, and then as the robot was coming along, I started doing the robot. Well, while this was all going on, I was seeing all these patients come in, and it seemed like the patients were getting younger and younger. And then I knew that I had a family history of prostate cancer. My grandfather, my maternal grandfather, which is actually quite important now, we're realizing that the maternal contribution to a man's cancer risk is actually quite high. And we know this now because of the BRCA genes, as you guys have been familiar with. But that BRCA gene inheritance is from your mother's side. And my mother's father died of prostate cancer, metastatic prostate cancer. And I watched all that happen, and I was involved in his care and everything, and so I knew I had a risk factor. So I started checking my PSA in my mid to late 30s, you know, well before anybody else would have checked it. And my initial PSA was very low, but surprisingly, I think I was 40, and my PSA went from like 0.5, it went up to 1, and then the next year, when I was 41, it went from 1 to 1.8, and that's a big jump. Now we get PSAs around 4, that, you know, that's when we start going, but when you're 40 years old, a PSA that number, that's actually quite a high number. And so I checked it again 6 months later, it went from 1.8 to 2.5, and I got scared. So I asked my partner to do my biopsy, and this was in 2006 at the time. I had left the University of Washington. I went to Swedish in 2005. So my partner at the time did my biopsy, and I indeed had Gleason score 3+3 cancer. And I had about 3 cores, low volume disease. But because I caught this very early with the PSA that I was checking, I made the diagnosis, but I was 42 years old, so I was very young. So I did the thing that all you guys have done. You get this diagnosis and you think, gosh, I'm healthy. I was 42 years old. I had my whole life in front of me, and so I'm gonna watch it. I'm gonna put my head in the sand. I'm not gonna deal with it. I'm gonna watch it. And I knew that was the wrong answer, but I started talking to some people in the field that I knew, and I was just in denial. And then I looked at radiation. I looked at surgery, and at the time, robotic surgery, 2006. I mean, it wasn't that established. It was still pretty young, and the outcomes were very preliminary. But I guess the benefit of doing what I was doing is that I kind of knew who was who in the field, and so I went and saw Vip Patel, who's actually a good friend of mine, and saw his procedure, and I had the ability to go watch them. I went and watched Manny Menon do it at the time. He was one of the early guys at Detroit. And then actually a good friend of mine, a guy named Tom Allering down at UC Irvine, was one of the early adopters too. He started doing this about the same time I did, 2003. And I went and watched his operation. And I basically, after all the decision making and everything I looked at, and I looked at radiation, I actually, Swedish was actually, at the time that I went there, a very prominent center for brachytherapy. They actually started brachytherapy. If you were doing brachytherapy in the world, you actually had come to Swedish for training. They started brachytherapy experience there. And so I was, I talked to the radiation people, and ultimately, given my age and everything else, I decided on the robotic surgery. And for me, the decision process was, I wanted to get rid of my cancer, but I also wanted to feel down the road that I didn't have to look over my shoulder. And so, I think radiation is a good option for some men, there's no question. But for me, being young, if I had a cancer recurrence in the future, I wanted that option of having radiation afterwards. So that's why I chose the surgery. I also knew that the biopsy doesn't always tell us how much cancer we have, and that it will underpredict. When you compare the biopsy to the final pathology, the biopsy doesn't tell you everything. So having the pathology was also good. And then the PSA after surgery is actually much more reliable than after radiation. So for me, it gave me what I call closure. That's ultimately why I decided with surgery. I was going to know what my PSA was, I knew what my biopsy, my true pathology was, and then if I needed something in the future, I could get it. So, 42, went down to Irvine, had my surgery, and it's very interesting what happened, because I was friends with this guy, and we're still friends, by the way. I don't want to say was, like we're no longer friends. But this is what happens when you operate on a doctor. So I had the surgery. Well, let me back up a little bit, because I'm going to tell you what happened, but there's something that happened in that experience, and I may have shared some of this as a patient to you guys who are patients of mine. But so I remember I went down there, and my significant other at the time, she met me there. She actually was living in Miami, so we met in LA, and I saw Tom the day before in clinic, and then the next morning, and so when you're a doctor and you know everything that can happen, you think you know everything, right? But you don't. Okay, you don't know anything actually. So the next morning, I'm getting ready to go to surgery, and I went and ran. I think I ran like 4 miles or something, and then I don't want to be offensive, but I had sex with my wife where I thought the last time. I thought, well, this is it. What's going to happen after this? I said, well, at least we had that, and then I go to the hospital, and so I get in the hospital. I'm going through everything, and I'm very nonchalant about the whole thing until I'm in my gown in the pre-anesthesia area, and the anesthesiologist walks in to introduce himself, and I went from very calm to like a huge anxiety moment. And it's because I realized that this whole process where you give your body to somebody else to take care of for a while, This whole process only happens with trust. And I didn't realize that as a doctor, believe it or not. I had operated on hundreds, thousands of people, and I didn't realize that the whole basis of this process was trust. That my patients, when they came to see me, put their complete trust in me. And what I realized at that time is that I had to trust that Tom Allering had enough sleep the night before, was not fighting with his wife, was completely focused on my care for that moment. And I will say this, that, I would never wish anybody to have cancer, but for me, that experience changed my practice, changed my life as a doctor. And it changed everything for the better. So that was like an epiphany. That was an epiphany right before, and it's actually the best thing that ever happened to me. And I think it's the sole reason for my success and what I've done, and why people come from all over for me to touch them and take care of them, is because I understand what it's like to be in those shoes. And yeah, there's the calf and everything, and yeah, there's the incontinence, which I had, and all the issues. But it's the trust thing that I took away from that experience that changed everything. So what happened was I had my surgery, and I woke up and I have a catheter in, and the pain is not bad, it's manageable. But what they do usually that night is they want to get you up and walk you around. So it was very interesting. I was in this kind of outpatient surgery area. That was where I was recovering. And it wasn't in the hospital. And I had this, I'll never remember, I'll never forget it. I had this little Filipino nurse. She was this tall. And she was, it's interesting. I mean, I only can say this. You guys probably can't relate this, but a lot of people that work in hospitals are Filipino. That's just the way it is. And they're incredibly wonderful, nice, and they're very helpful. But she had this very, common accent that I was used to in the hospital, the Filipino accent. And she's saying, "Okay, Dr. Porter, we're going to get up. We're going to get up. So I want you to stand up, and I want you to take a step." So what happened was I stood up, and I felt fine, and I took one step like this, and I fell forward over her. I fell on her. And I was laying on her, and I had to roll off of her. But I had no strength in my legs. Zero strength. And I couldn't get up. So they had to call people to pick me up and put me in bed. And I just was like, what is going on? I had no strength in my legs. And I thought maybe it was the anesthetic or whatever. Well, it turned out, and I said this because it's fitting, because this is what happens when you operate on doctors. The position he put me in was based on the bed that he had. And in order to get, any of you that have robotic surgery, but this has happened to you, in order to get the robot in, so people are upside down essentially when we do the surgery, head down, the legs are up. But if the legs are so high, you can't get the robot in, you can't get the robotic arms in. So what you do is you bend the legs down, even though the patient's still kind of in the upside down position. They're about 20 degrees head down. That's the standard position. Well, I have a bed that bends the patients at the knees. And so there's no problem, because the knees actually bend this direction. Dr. Allering's bed bent the patient at the hip. Oh, no. So I was jackknifed like this for 4 hours, and I stretched and paralyzed my femoral nerves bilaterally. Oh, so I had bilateral femoral nerve palsy. I stayed in the hospital for a week. I left with a front wheel walker, which I used for 2 weeks beyond that. This is a story I don't tell hardly anybody. Yeah. But I had a major complication from positioning. But I felt it was justice because, I don't say this commonly either, but, the reality is, where I am now as a surgeon happened because of a lot of experience on people before me. And a lot of things that didn't go well. And a lot of things that I learned because of that. So it's like you always hear that saying, we stand on the shoulders of the people before us. Well, I stand on the shoulders and the hips and the prostates of people that I operate on before a lot of people. And that's the reality of medicine. And people may or may not want to talk about it, but everybody that gets to a certain point has issues that allow them to get to a better place. Well, I felt it was fitting that I experienced that, because that seemed like almost justice for the issues I caused other patients. So, but it's part of the deal. And so I had this palsy. I left the hospital a week later with a walker. I had pins and needles, with the nerves waking up for 9 months. Just pins and needles in the top of my thighs.
Mhm.
But my prostate was out, and I got through it. So it happens. Complications happen. Surgery is not, without issues. And fortunately, and Tom was in his first 200 procedures then. I mean, he was early in his experience. Now I've done 3,000. So we don't have issues. We hardly have issues at all anymore. The bleeding's gone. The positioning issues were long over. But we've had issues, and occasionally we do still have issues. But it's part of surgery. It really is a part of surgery. So now I'm 12 years away from that surgery. PSA is undetectable. My functions came back. Not immediately, but they came back. And for me, it was the best decision ever. And I'm glad it's behind me. I'm glad I'm not worried about it. If I hadn't checked my PSA at that point, I don't know when I would have detected it, at what stage I would have detected it. And, it could have been a much different story. So that's a little personal reflection.
Thanks for sharing.
Yeah. And it kind of gets me to the whole thing. So right around, you guys are all familiar with the task force. So in 2012, the task force came out with a very concerning recommendation about PSA. And, it was that we should really not be checking PSA, and that the test itself, leads to harm, and that people are being overdiagnosed and overtreated, and that this is a bad test. And the data that decision was based on was interpreted in a very poor way, and we know that now after looking at the way that the interpretation was done. But it always was curious to me, because the people that sat on that panel, these are very smart people. These were epidemiologists with, a long history of understanding the medical literature and what contributes to the kind of issues that they were trying to prevent. And for me as a doctor, as a surgeon treating cancer, prostate cancer, as well as a patient, I found the recommendation just baffling. I just couldn't understand how you would not want to understand what was going on with a cancer that really has no symptoms, and that if you find it, later in the disease, it's much different than finding it earlier in the disease. And, I think the recommendation was a response to the history of prostate cancer as it evolved. And it's almost like, when you're discovering something and, you don't know much about it, and you're doing things to try to learn more about it, and during that process you make some mistakes. Well, I think that happened. I think as we understood prostate cancer and as it changed, there were people that really got overtreated that didn't, but we didn't understand the natural history of prostate cancer, and we really still don't understand it as well as we think we do, because there's some guys that still will just progress very quickly, and other guys that will stay at a very, very low level. So it seemed very irresponsible to recommend completely getting rid of the only test that helps us determine, who has prostate cancer at an early stage. And I think what we realized is that we needed to disconnect the diagnosis of prostate cancer from the treatment of prostate cancer. If you treated everybody that was diagnosed, then you're going to overtreat some men. There was no question. But you don't have to do that. You can disconnect the two, and you can do that responsibly, and you can still find the guys who are going to have the aggressive cancers that are going to benefit from treatment, and still and not put those patients at risk. So what we've done since 2012, and actually we just had a paper published in the World Journal of Urology with Tom Allering as one of the authors, myself, where we actually looked at our data since 2012 and looked at how prostate cancer has changed. And what we found is that we're diagnosing more and more high-risk cancer at a higher PSA, at a later stage, and the patients are not doing as well than they were before. So we've traded one problem for another. Maybe we've gotten rid of treating some patients, but now we're finding guys later, and we're not able to help them. We're not able to do it in the way that we could. So that to me has been a big change in what we've done. And now, so for example, before 2012, I would do a lymph node dissection. So a lymph node dissection I do with a prostatectomy in certain situations. And I do that if the patient has a risk of having lymph node involvement that warrants putting them through the risk of a lymph node dissection. So what does that mean? So first of all, I don't want to digress too far from the task force. I'll get back to that. But removing the lymph nodes, and lymph nodes are areas in the pelvis where prostate cancer spreads to. And based on the experience of others, there's certain lymph nodes that have a higher chance of being involved. So we focus on those lymph nodes. And you can remove lymph nodes and really not have any real downside for the patient, because these lymph nodes, there's thousands in your body, and I on average remove about 20 or 30. So there's no function that we decrease by removing lymph nodes. But there's a risk involved, and the risk is these lymph nodes surround the artery, nerve, and vein that go to your legs. And so if you injure those, and this is a different injury than what I'm describing with the positioning, but if you injure the artery, nerve, and vein that go to your legs, then you can have real leg problems that don't go away. So you don't want to put somebody through that risk if the chance of finding cancer in those lymph nodes is really low. So we use things like nomograms, which are predictive tables, which are created based on looking at thousands of men. And what they do is they take their preoperative numbers, their PSA, their Gleason score, and the amount of cancer, and they compare them to what was actually found in the pathology. And what that nomogram does is it predicts the risk of having lymph node involvement, the risk of having cancer outside the prostate, the risk of having seminal vesicle involvement. So we use this as a guide. So the nomograms that I use is from MSK, and my cutoff is 4% or more. So if you have a 4% or more chance of having lymph node involvement, then I think it's worth the risk, because my risk of causing a complication is about 4%, if you look at the data. So if I have a greater chance of causing a problem than I do of finding cancer, I don't do it. But if I have a greater chance of finding cancer than I do of causing a problem, then we do the lymph node dissection. And lymph node dissection adds about an hour to the procedure extra, and it's probably the most complicated part of the operation. It's much more complicated than taking the prostate out, and it's much more risky. So we only do it in patients where we think it's warranted. So my story is, before 2012, based on the nomogram, I would do lymph nodes in about 1/3 of my patients. Now I'm doing lymph node dissections in 2/3 of my patients. That's how things have changed. That's what we're treating now. We're treating patients, and I'll tell you the rate of lymph node positivity. What does that mean? So when I take out lymph nodes, a certain percentage of patients will be negative. Actually, the majority will be. My positive lymph node rate prior to the task force was around 18%. Now it's 35%. Meaning that we're seeing more and more patients with positive lymph nodes. Positive lymph nodes, you can live with positive lymph nodes for a long time with prostate cancer, but it puts you in a different category. There's no question about it. So the task force has changed the disease. And I think, yes, we all got the memo that we should be not treating everyone. I think that was clear. But I think, unfortunately, we've done it at the risk of some men being found at a much later stage. So that's something that we are still, dealing with. And I think it really is going to mean that we're going to be treating a lot more patients with advanced prostate cancer. Another recent advance, which I think is really helpful, is the PET scans that you may be familiar with. So PSMA PET, the Oxymin PET scan, which we offer in Swedish. Before those two, the precursors of those two were the acetate and the choline scans, which you could only get at a few centers. And why? Because choline and acetate and PSMA, they all require something called a linear accelerator. This linear accelerator makes the radioactive material that they use as the tracer. And these radioactive isotopes have a very short half-life. So if you don't have an accelerator right in your institution, you can't do the study. So that's why you had to go to Mayo, or you had to go to Arizona for the acetate scan, or Mayo for the choline scan, because there was only a couple places that had it. PSMA has become a little more common because you don't need as much of because there's something called gallium. Gallium is a radioisotope with PSMA, and you don't need a linear accelerator. You do need some type of technology to make the gallium, but you don't need a huge, $3 million accelerator. And then the most recent PET scan is the Oxymin scan. So how is PET scans going to change what we do? You know, when we do prostate cancer surgery, for example, or we do radiation on someone, and their PSA goes up afterwards, we talk about treatment options based on where we think the cancer is, but we really don't know. So, for example, if I've done surgery on somebody here, and you have a rising PSA, and then we talk about what do we do? So the options are we radiate where the prostate gland was, and maybe there's some cells that were there, or do we give you hormone therapy or chemotherapy to treat the entire body? That's kind of the two big broad categories. So either local treatment or systemic treatment. Well, for many years, we were giving radiation to people that we didn't really know if they had cancer in their pelvis. So if you radiate them, their disease is not going to change. Now, why would some men who got radiation see a change in their PSA with radiation? Because they were getting hormone therapy at the same time in many cases. So the hormone therapy was treating the entire body. So if they had cells elsewhere in the body, their PSA would go down. So it looked like it would work. But when they stopped the hormone therapy, lo and behold, their PSAs would many times go up. So when we treat something without knowing why we're doing it, we call that empiric treatment. That's empiric, right? We'd like to get away from empiric treatment because we'd like to know that if we're doing radiation to the pelvis, there's actually prostate cancer cells there. That's what these PET scans can do. These PET scans can change our kind of, shotgun approach to, oh, you don't have cancer in the pelvis, your cancer's actually up here in the abdomen, you shouldn't get radiation, you should get hormone therapy and possibly chemotherapy after that. We've now used this scan commonly in patients who've had radiation therapy who don't get lymph node dissections or things like that. And we found many people actually do have positive lymph nodes where the cancer is. So I've gone in after those patients, taken out their lymph nodes, and we've actually affected their PSA. We've dropped their PSA. Now, does that mean we've cured them? We don't know that yet. It's still too early to tell because the problem is you can take out these lymph nodes and the PET scan's positive, but the PET scans have a certain sensitivity, which means that you might have a negative scan and still have cancer elsewhere in the body. So the scan might have showed you something in the pelvis, but there could still be some cancer up here in the lymph nodes. So that's why it may not be a cure. But in certain patients, it could help us. But I think PET scans eventually are going to be used earlier in the diagnosis of prostate cancer. Let's say before you've had surgery or before you've had radiation, you get a PET scan. And maybe that's going to help determine what you get for treatment. Maybe if you've got positive lymph nodes here, let's say you walk in with a PSA of 50, all right? You have a very high chance of having lymph nodes elsewhere in the body. Maybe that's the patient we should be doing a PET scan on. So I think I think these PET scans are really going to be helpful in what it goes to show us is that we don't know as much about prostate cancer as we think we do. And we're learning more and more about it. As we do these studies with PET scans, we're actually learning that our ideas about where prostate cancer is when we treat patients is probably not accurate. And if we do more and more of this, I think the PET scans are going to be more and more helpful. I'm just kind of freelancing here with thoughts, but yeah, sure.
Just a question that would be selfish,
Sure.
you're asking this. So, do you have experience with PSA and scans? I mean, how much PSA, I know it's a toughie.
On the PET scans or what?
Like me, I'm 0.05 right now.
Right.
And I was told by my doctor that it needs to be at least at 0.5
0.5.
or
So
so.
10 times where you are now. So these scans have a sensitivity, certain sensitivity, and we find that below 0.5, these scans are, you may have cancer, but it's not going to be seen on the scan. So it may be what we call a false negative study, and so that's not going to be informative, or it's not going to help, change your care. So so you need to get, a little higher PSA before those scans will be informative.